Support for this program is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. There's more to explore. Discover all the data at vabysmo-hcp.com. That's vabysmo-hcp.com.
Welcome to New Retina Radio. I'm your host, Dr. John Kitchens, and we're talking today about a dual pathway inhibiting therapy for the treatment of patients with neovascular AMD and patients with DME. My guests today need no introduction, but I'll introduce them regardless. Dr. David Chin Yee, who's with Georgia Retina. David, welcome to the podcast.
Thank you. So happy to be here and looking forward to talking to this exciting topic.
Awesome. And our second guest, Dr. Margaret Chang, who's with Retina Consultants Medical Group in Northern California, focused mainly in the Sacramento area. Welcome, Margaret.
Thanks so much, John. Happy to be here.
This special episode of New Retina Radio is supported by Genentech, which is responsible for the content. We have been compensated by Genentech to serve as speakers for this program. This program is intended to provide general information about Vabysmo, faricimab, SVOA, and not medical advice for any particular patient. Any adverse events included in this discussion today have already been reported to Genentech Drug Safety, and no action is required by any listener. Vabysmo, or faricimab, SVOA, is a vascular endothelial growth factor, or VEGF inhibitor, and angiopoietin-2, or Ang2 inhibitor, indicated for the treatment of patients with neovascular or wet age-related macular degeneration, or diabetic macular edema, or macular edema following retinal vein occlusion. Vabysmo is contraindicated in patients with ocular or periocular infection, in patients with active intraocular inflammation, and in patients with known hypersensitivity to faricimab or any of the excipients in Vabysmo. Hypersensitivity reactions may manifest as rash, pruritus, urticaria, erythema, or severe intraocular inflammation. Well, we have a lot of topics to cover today, and I'm really excited to get David and Margaret's perspective on dual pathway inhibiting therapy for treating patients with neovascular AMD. David, I'm going to start with you, and let's think about specifically retinal vascular disease, diabetic macular edema in particular. What is your primary goal of therapy when treating patients with any agent for diabetic macular edema?
Well, I think what's the most important thing for patients and their goal would be to prevent or reverse vision loss, right? They're coming in many times with having difficulties seeing, which is why they're coming to us, either being referred from by their referring specialist or coming to us because they're noticing new changes. So that would be my primary goal, and the patient's primary goal is gaining vision, right? Or even hopefully preventing further vision loss that they may be experiencing with their disease at this time. And as you mentioned, one of the tools or agents we have available to us is intravitreal injections, which we've been doing for many years now.
And would you say, David, that intravitreal injections are your primary therapy for patients with diabetic macular edema?
No question. For any retinal vascular disease at this point, especially diabetes, my go-to agent are intravitreal injections.
And how do you assess the efficacy of intravitreal injections? In fact, how do you utilize imaging to maybe identify which patients might respond better to certain therapies?
We look on this theory in terms of how much fluid may be present. Definitely using an OCT. It's probably the number one imaging modality we use on a day-to-day basis is optical coherence tomography. And the symmetrical nature, if there's agents such as hard exudates, those are some factors that I look into to determine, hey, this may be more chronic. These patients may be a little bit more difficult to treat. I do tell my patients a lot of time, the idea is I want to get response as quickly as I possibly can. I give the example, if a pipe bursts in your house, the idea is if that water is in the floor, the longer it's there is the more permanent damage is likely to occur. So there's no question, just like if a pipe bursts in your house, you're going to try to dry it up, get rid of that fluid or water in the house as quickly as possible. Same idea that I look for my patients. I want to get an agent that is going to allow the disease to be resolved as quickly as possible. And I use the OCT to help to determine, is there resolution or improvement in fluid on examination?
And what role do you have for fluorescein angiography, if any, in this day and age, David?
For diabetics, I definitely try to do FAs, especially on the first visit. Honestly, I do not usually repeat examinations of FA, but I do think it's valuable in terms of allowing us to get an idea of the peripheral perfusion. and getting baseline idea of where the patient's standing when I'm first seeing them at the initial visit. One of the issues that I've had recently was there was a point where we had difficulty sourcing fluorescein, but thankfully that has kind of resolved, and so not having as many issues with that at this current time.
I'd like to transition to Margaret now. Dr. Chang, this podcast is focusing on a dual pathway inhibiting therapy for patients with neovascular AMD and DME. What is dual pathway, and what is the role of Ang2, Tie2 in treating patients?
Well, we've all heard about the importance of VEGF in retinal vascular disease. But, what we're now appreciating more readily is that the effects of VEGF are really potentiated by Ang2. So going back to the basis of the angioprotein axis, it really centers around the Tie2 receptor, tyrosine kinase, which is expressed on the surface of endothelial cells. And now when Tie2 is bound by Ang1, endothelial cell junctions are tightened and parasites are recruited, and basically there's overall vascular stability. But on the other hand, when Ang2 is activated, and that's really upregulated in times of hypoxia and inflammation, Ang2 binds Tie2 receptors, and then we have promotion of vascular permeability, angiogenesis, and inflammation. Ang2 does this independently by promoting leukocyte migration and parasite dropout. These are key drivers of vascular instability and leakage. But importantly, it really does sensitize these blood vessels to the effects of VEGF as well. And so the end result is going to be neovascularization and increased vascular permeability. So, Vabysmo, of course, is the first bispecific antibody that has that ability to inhibit both Ang2 and VEGF. So it blocks two key drivers of retinal vascular disease.
Well, that was a fantastic answer about the pathophysiology and effects of VEGF and Ang2, Margaret. Now, it's important to note that the contribution of Ang2 inhibition to the clinical response for neovascular AMD, DME, and RVO has yet to be established. I'd like to transition now into the studies that led to the approval of faricimab or Vabysmo for the treatment of both wet macular degeneration and diabetic macular edema. First, the Tenaya and Lucerne studies. Now, the Tenaya and Lucerne trials were both 2-year phase 3 studies in newly diagnosed treatment-naive patients with neovascular AMD. They were designed to evaluate the efficacy and safety of faricimab versus aflibercept. These were identical 2-arm studies composed of Vabysmo's 6 milligram arm with a pooled patient total of 665 patients dosed at fixed Q8 week, Q12 week, or Q16 week intervals, and an aflibercept 2 milligram arm with a pooled total of 664 patients dosed at a fixed Q8 week interval after an initial loading dose phase. As far as the efficacy is concerned, Vabysmo showed first-line efficacy with extended dosing intervals by meeting its primary endpoint of non-inferiority versus the aflibercept 2 milligrams Q8 weeks, which was assessed by a mean change in best-corrected visual acuity at year 1, basically looking at weeks 40, 44, and 48. And in the Vabysmo extended interval Q8 week to Q16 week arm, patients gained an average of 6.2 letters versus 5.9 letters in the aflibercept 2 milligram Q8 week group. So David, I briefly kind of outlined the design of the studies, the outcomes of the study, but what's the real take-home message for retina practices and retina specialists about Tenaya and Lucerne? How can you use that study to really help guide your treatment of patients?
Well, again, great results. Thank you for such a great review of the data. What I take away from it is how amazing that we can get these visual outcomes in terms of improvement with less treatment, right? That's one of the first things that pops out to me. Some of the things I pulled away from the trial as well is the fact that, one, these patients could get extended out to potentially 4 months. Prior to many of these studies, we were not extending our patients with wet age-related macular degeneration out to 4 months. So again, that was reassuring to me also. Another thing was the extension phase where they were able to extend patients at an every 4-week basis. Usually in the clinic, we primarily extend patients on an every 2-week basis. This provides more data for us to be more comfortable, allowing us to have patients be extended potentially every 4 weeks or monthly and up to 4 months, while also allowing them to gain similar outcomes in terms of visual acuity, which, as I mentioned earlier, is probably one of the main things as a retina specialist we're looking to achieve.
So in your treatment-naive patients with wet macular degeneration, when you utilize Vabysmo, you're actually taking and extending these patients by 4 weeks once you've got them stable?
Yeah, I'm starting to do that now and I'm getting good results. And as I said, primarily, this is not something I was very comfortable with. I used to have patients come back every 2 weeks when I was extending the patient, but now that I have something to somewhat rely on, I feel a little bit more comfortable allowing these patients to go an extra 2 weeks in between treatment.
And you brought up a great point about extending all the way out to 4 months. I, like you, was not someone that felt overly comfortable taking patients out beyond that 3-month barrier. And now I agree with you. I feel, since we have data to back it up, that I am more comfortable getting the stable patients out to 4 months. Are you finding the same thing?
Oh, yes. I look on it and I'm seeing a lot more of my patients are being able to be extended further and further out, which is something that I'm excited for, right? We are truly looking for the capability to provide somewhat flexibility for our patients. And again, at the same time, focusing on having a drier retina on examination and treatment. And that's what I'm able to achieve.
I'd like to transition now over to the diabetic macular edema studies. The Yosemite and Rhine trials assess the efficacy and safety of Vabysmo versus aflibercept. These were 2-year phase 3 studies conducted in treatment-naive and previously treated patients. They were identical studies. They included 3 arms. There were 2 Vabysmo arms with a pooled total of 632 patients in each group, as well as an aflibercept control arm with 627 patients in it. The aflibercept group followed a 2 milligram fixed Q8-week regimen, while the Vabysmo group was treated either with a fixed Q8-week or a variable Q4, Q8, Q12, or Q16-week regimen after the completion of a loading phase. This was really modeled after a real-world treat and extend paradigm. Patients were assigned to one of 3 regimens based on disease assessment criteria such as CST or OCT results and visual acuity evaluations. The Vabysmo treat and extend dosing did not mandate waiting for vision loss before intervening, and intervals could be primarily driven by changes in OCT and not visual acuity combined with OCT. Vabysmo met its primary endpoint of non-inferiority versus aflibercept 2 milligram Q8 weeks, which is assessed as the mean change in best correction of visual acuity at 1 year measured over weeks 48, 52, and 56. At year 1, patients in the variable dosing Vabysmo group gained an average of 11.2 letters versus 10.5 letters in the aflibercept arm. And importantly, these gains were maintained through year 2 with an average of 10.8 letters gained in the Vabysmo group versus 10.3 in the aflibercept group. CST reductions were observed in all treatment arms. And after the 4 monthly loading doses, patients in the Vabysmo Q4 to Q16 week arm received a median of 7 injections over 2 years. And this was a possible max of 21 injections with a median of 3 in year 2, the possible max in year 2 of 10. So with that study design and clinical outcomes of the trials in mind, Dr. Chang, how have the results of the Yosemite and Rhine studies changed your management of patients?
Well, I think that, first of all, it's great to see that these 2 trials had this personalized treatment interval that really does mirror what we do in clinical practice. And so instead of having to extrapolate how the drug can perform in a treat and extend fashion from fixed dosing data, now it is seen in these clinical trials that Vabysmo is just as effective as fixed 8-week dosing with aflibercept with fewer injections. And of course, a lot of patients with diabetic macular edema are working age patients. They don't want to come in and see us all the time. They really do want to extend out their treatment intervals because that means fewer visits for them, less missed work. Even for patients who are, for instance, in the Medicare age, who need treatment for diabetic macular edema are going to need to come with a caregiver. And that caregiver is going to need to miss work in order to bring these patients to the office. So I think that it is remarkable that over 70% of the clinical trial patients were able to achieve Q12 or Q16 week dosing at a year, and that over half of them were able to achieve every 4-month dosing. I think that's absolutely spectacular.
Now, I really love what a dynamic trial this is. The fact that we not only could extend patients, but patients could be reduced on their injection intervals, and very, very true to life with how we manage our patients.
Right.
I want to focus on the over 40% of patients that were previously treated. What does it mean to you to have a study that has so many previously treated patients in it?
I think that this is very true to life to how we actually treat patients in the real world. We're always trying to find the right agent in order to best treat their diabetic macular edema. And so having previously treated patients in these studies is really helpful to see how it would actually work in the real world. And again, it's a testament to the study design as well.
4 really great studies, very innovative studies in the way they were designed. I think it's important with any of these clinical trials to not only look at the efficacy, but also the safety. Throughout all these studies, Vabysmo demonstrated similar safety to aflibercept. Across these trials, the most common adverse reactions reported in patients receiving Vabysmo included cataract and conjunctival hemorrhage in the DME trials, conjunctival hemorrhage in the neovascular AMD trials. It's important to note that intravitreal injections that inhibit VEGF, including Vabysmo, have been associated with endophthalmitis and retinal detachment, increases in IOP, and arterial thromboembolic events. The incidence of reported arterial thrombotic events was 1%, or 7 out of 664 in patients treated with Vabysmo, compared to 1%, or 6 out of 662 in patients treated with the aflibercept. There were no cases of vasculitis with or without occlusion reported across the 2,500 clinical trial patients who received Vabysmo. Now, retinal vasculitis and or retinal vascular occlusion have been reported with the use of Vabysmo in the post-marketing setting. So, Margaret, I'll come to you first. The safety results of these clinical trials, are they reassuring, as reassuring as other agents that we've been familiar with and using for the last decade?
Well, given that the rate of serious adverse events was similar between treatment groups in the clinical trials, I thought the Vabysmo safety data was actually reassuring. And, in my own clinical practice, I have had a few rare cases of intraocular inflammation that was limited to anterior chamber reactions. They were successfully treated with topical steroids. In my 16-person practice here, there haven't been any cases of retinal vasculitis, but of course, we always caution patients to report symptoms to us as soon as they experience any increased floaters or decreased vision or any pain after injection. So we're very vigilant about bringing in symptomatic patients urgently.
I've actually had a case of a patient who had bilateral retinal vasculitis and inflammation, and it was non-occlusive. And I can say, as someone who's seen a lot of other agents that have caused retinal vasculitis, my case at least really did not look like that scary, very occlusive vasculitis. It was just disc leakage and some vascular inflammation. Patient did very well with conservative management, topical steroids, some oral steroids, and she improved back to her baseline. So I hate to say that all cases of retinal vasculitis associated with Vabysmo are going to do rather well, but it certainly seems like it's a different animal than what we've seen with other agents out there. Well, listen, I've learned a lot through the first half of this podcast. We're going to take a little break. I want to remind listeners to come back for part 2, where we're going to discuss some real-world patient cases with Dr. Chin Yee and Dr. Chang.
Support for this program is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. There's more to explore. Discover all the data at vabysmo-hcp.com. That's vabysmo-hcp.com.
Welcome back to New Retina Radio, dual pathway inhibiting therapy for patients with neovascular AMD and DME, perspectives from the real world. Really looking forward to this part of the podcast, as this is when we're going to talk about patient cases. And David, you have a patient with wet macular degeneration. Tell us a little bit about your patient.
Sure. This is my 76-year-old Caucasian male presented with classic occult CNV in July of last year. And on OCT, which I know you can't see at this point, but the patient did have a nice pigment epithelial detachment, as well as subretinal fluid and intraretinal fluid. And they were noticing a change in vision. Visual acuity was actually 20/30 minus a couple of letters. So you might say, still pretty good vision, but this patient was definitely symptomatic. Difficulty reading, and actually has also difficulty with hearing, and so is very dependent on actually subtitles. And actually, that's where they actually noticed the difference, is having a lot more difficulty reading the subtitles on television screen. The central subfoveal thickness on presentation was 332 microns. And then this individual, again, as I do classically or more commonly on my patients, I try to get them on one of our newer agents or next-gen anti-VEGF medications. And the sole purpose, again, is to try to obtain disease control as quickly as I possibly can. And here you can see after treatment, I had the patient receive injections monthly in a loading dose fashion, and improved after 3 injections. The central subfoveal thickness improved down to 244 microns. At which point, after loading, I did start to extend the patient out again from every 4 weeks out to week 20, and again, vision continued to be improved. There was no recurrence of subretinal fluid or intraretinal fluid, and decided to further extend the interval from 4 weeks going out to now 10 weeks. And at this point, the patient's vision stabilized at around 20/30, and central subfoveal thickness improved to 212 microns. Again, what I like to show here is how quickly this patient had improvement and response in terms of resolution of the subretinal fluid. And you can see here the pigment epithelial detachment, actually, there was also improvement. And in my personal experience, I find that patients with a pigment epithelial detachment, they tend to have some improvement as well. It was also very nice that this patient was able to be extended smoothly without any hiccups, without any recurrence of fluid. And again, suggesting better control, better stability of this disease process, which I believe potentially allows us to be able to maintain vision and allow even further recovery and maintenance of vision.
Yeah, I'm really impressed by being able to extend this patient out so quickly to the 10-week level and that control of the leakage. Talk to us a little bit about the era of tiered therapy and insurance. For this patient, you were able to get him quickly initially over to one of the more recent therapies, Vabysmo. But how do you navigate that, David, that tiered therapy that many insurances make us step through?
Yeah, as you mentioned, I would tell you that's one of the more frustrating things that as a retina specialist we face with on a day-to-day basis. Ideally, as I mentioned, I want to get them on something that I consider one of the newer generation anti-VEGFs to be able to maintain disease control. And unfortunately, due to step therapy insurance mandates, a lot of times we have to use other agents. But again, if it were me or many of the patients, they want to get there potentially sooner, right? Even if you look at the area under the curve in terms of fluid resolution, being able to get there faster, potentially, or sooner, we know there may be a benefit long-term on these patients. I also like the ability to have less fluctuation, right? Not having recurrence of fluid between each visit. I also think that maintaining control is also very important.
And David, no side effects or safety concerns with your patient?
Thankfully, there are no safety issues or adverse events that occurred with this patient.
I'd like to transition over now to Margaret. Margaret, you have a patient with diabetic macular edema that was a previously treated patient. Tell us a little bit about your patient.
Yeah, this was a 62-year-old gentleman. He had a history of type 2 diabetes for 15 years, recently well controlled with hemoglobin A1C of 7.4. When he first presented to me, he had proliferative diabetic retinopathy in both eyes and no DME in the left eye, but he did have some DME in the right eye. And of course, just as Dr. Chin Yee had described, we often have to step through step therapy in order to get to where we want to be. So he had to be treated with bevacizumab first. I gave him 1 dose, and then after his edema resolved, he was treated with PRP in both eyes and needed 2 sessions of PRP. I then followed him for another 6 months. So he didn't have any edema or any neovascular complications, But 9 months after his initial presentation, he did develop DME in both eyes. The baseline CST in the right eye was 378, and in the left eye, it was 476 microns. His best corrected vision at the time was 20/70 in the right and 20/40 in the left. So I initiated Vabysmo treatment in both eyes. Of course, the right eye had been previously treated with bevacizumab. The left eye was naive. And I had to give him 4-week doses until he stabilized around 300 microns on the OCTs. His best corrected vision had stabilized to 20/30 and 20/40. And he was given 4-week doses for approximately 8 doses. After 36 weeks, I was able to get him out to a Q8 to 10-week dosing schedule. And at his last follow-up at week 74, he was extended all the way out to 12 weeks. And he was very stable with OCTs under 300 and best corrected vision of 20/40 in both eyes. So I was really pleased by his response to Vabysmo. Some of these patients, once they've developed a lot of edema, can be quite hard to control. I'm sure that you found as well, Sean, that diabetes is a heterogeneous disease, but Vabysmo seems to give, in my personal experience, a very good result for these diabetic patients.
Yeah, Margaret, I'll tell you, that's impressive. The impressive part is just the rapid resolution of the edema that you achieved. I think by week 8, that left eye had gone from almost 500 microns down to 250 microns. Is that surprising? Is that what we should expect with faricimab?
Well, not every single patient is going to behave the same way. But this patient, I think, because he was treatment naive, had not had edema around for a very long time. And so I think it is harder to treat patients who've had chronic edema with any agent.
And the role of fluorescein angiography in your diabetic patients, are you routinely getting fluorescein angiography, or is it all just OCT at this point?
So I generally do a fluorescein on the first visit. I mean, I do think that it's helpful in terms of assessing macular leakage as well as peripheral non-perfusion. If the patient is not proliferative the very first time, I do repeat the FAs probably on a 6 to 12 month basis as fluorescein is available. If their main issue is macular edema, then I have to say that I depend mostly on the OCT to define my treatment. So I will keep on treating as long as there's, fluid or cystic spaces on that OCT.
And as far as tiered therapy, we talked about it in neovascular AMD with David. What about in your diabetic patients? Are you finding it's more difficult to get them over onto a newer therapy, or is it sometimes easier?
Well, unfortunately, I live in a corner of the world where we are very heavily managed with capitated insurance plans, Medi-Cal, and Medicare Advantage plans. So there often is going to be step therapy that's required. Our drug authorization team has done a really good job at letting us know how many steps we have to go through before we can move on to the next drug and which drug is next in that step. So I think it's important for retina specialists to try and streamline the process so that we can get our patients on the best therapy possible as quickly as possible.
And no safety issues in this patient?
No safety issues for this patient. He's more than thrilled that he does not need injections from me that often.
Well, that was fantastic. It was a really wonderful and insightful conversation. I want to thank Dr. David Chin Yee and Dr. Margaret Chang for joining me tonight on New Retina Radio, a dual pathway inhibiting therapy for patients with neovascular AMD and DME, perspectives from the real world. Watch for episode 2 of this podcast, where I'm joined by Dr. Maria Baracol, and we talk about dual pathway inhibiting therapy for patients with diabetic macular edema and her perspective in the tough to treat patients in Puerto Rico. Very fascinating.
Important safety information. Indications. Vabysmo, faricimab SVOA, is a vascular endothelial growth factor VEGF inhibitor and angiopoietin-2 (Ang2) inhibitor indicated for the treatment of patients with neovascular wet, age-related macular degeneration (nAMD), diabetic macular edema (DME), and macular edema following retinal vein occlusion (RVO). Important safety information. Contraindications. Vabysmo is contraindicated in patients with ocular or periocular infection, in patients with active intraocular inflammation, and in patients with known hypersensitivity to faricimab or any of the excipients in Vabysmo. Hypersensitivity reactions may manifest as rash, pruritus, urticaria, erythema, or severe intraocular inflammation. Warnings and precautions. Endophthalmitis and retinal detachments. Intravitreal injections have been associated with endophthalmitis and retinal detachments. Proper aseptic injection techniques must always be used when administering Vabysmo. Patients should be instructed to report any symptoms suggestive of endophthalmitis or retinal detachment without delay, to permit prompt and appropriate management. Increase in intraocular pressure. Transient increases in intraocular pressure, IOP, have been seen within 60 minutes of intravitreal injection, including with Vabysmo. IOP and the perfusion of the optic nerve head should be monitored and managed appropriately. Thromboembolic events. Although there was a low rate of arterial thromboembolic events, ATEs, observed in the Vabysmo clinical trials, there is a potential risk of ATEs following intravitreal use of VEGF inhibitors. ATEs are defined as non-fatal stroke, non-fatal myocardial infarction, or vascular death, including deaths of unknown cause. The incidence of reported ATEs in the nAMD studies during the first year was 1%, 7 out of 664, in patients treated with Vabysmo, compared with 1%, 6 out of 662, in patients treated with aflibercept. The incidence of reported ATEs in the DME studies from baseline to week 100 was 5%, 64 out of 1,262 in patients treated with Vabysmo, compared with 5%, 32 out of 625 in patients treated with aflibercept. The incidence of reported ATEs in the RVO studies during the first 6 months was 1.1%, 7 out of 641 in patients treated with Vabysmo, compared with 1.4%, 9 out of 635 in patients treated with aflibercept. Retinal vasculitis and/or retinal vascular occlusion, typically in the presence of intraocular inflammation, have been reported with the use of Vabysmo. Healthcare providers should discontinue treatment with Vabysmo in patients who develop these events. Patients should be instructed to report any change in vision without delay. Adverse reactions. The most common adverse reactions, greater than or equal to 5%, reported in patients receiving Vabysmo were cataract 15% and conjunctival hemorrhage 8%. Pregnancy, lactation, females and males of reproductive potential. Based on the mechanism of action of VEGF and Ang2 inhibitors, there is a potential risk to female reproductive capacity and to embryo-fetal development. Vabysmo should not be used during pregnancy unless the potential benefit to the patient outweighs the potential risk to the fetus. The developmental and health benefits of breastfeeding should be considered along with the mother's clinical need for Vabysmo and any potential adverse effects on the breastfed child from Vabysmo. Females of reproductive potential are advised to use effective contraception prior to the initial dose, during treatment, and for at least 3 months following the last dose of Vabysmo. You may report side effects to the FDA at 800-FDA-1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888-835-2555. Please see additional important safety information in the full Vabysmo prescribing information.